So we said we need to have a plan for the patient's diabetes, like a medication regimen, discuss diet and exercise, look at the family history, and then patient education on any of the new medications. We also said change lovastatin to atorvastatin 40 or 80 milligrams, and then adding an H2RA because they are on dual antiplatelet therapy.
Very good. Group 5, do you have anything different or that you want to add to what was already stated? Since I can't physically see you, Group 5, if you don't have anything to add, I'm going to need you to tell me.
That was all we had as well.
Okay, thank you very much. Now, Group 15, you had mentioned come up with a plan for the diabetes. Was there anything that you guys are rattling around in your group that you wanted to start for treatment in patient? Was there anything that you guys discussed? Was there anything that any of the groups discussed that they wanted to start for diabetes treatment? If that was something that you talked about as transitions of care, can anyone who maybe discussed what they wanted to start go ahead and share that with me?
Group 25 talked about metformin, 500 milligrams BID.
Thank you.
Group 5 talked about starting basal insulin while in hospital.
Any different ideas than those two groups? So we have metformin 500 BID, we have basal insulin while in hospital. Anything else from any of the groups across the campuses?
Group 24 said a basal insulin drip, and then we can convert that to long-acting for when they discharge from the hospital.
Somewhere between 30 and 40.
Okay. I appreciate you guys sharing. Thank you for that. So, some of the things that I'm going to cover for you guys when we talk about what's going on in the cath lab as well as on the cardiac floor. You guys hit on a lot of the good points here. So, one of the first things you want to think about as the pharmacist looking at this patient who's made this transition, you're helping your team. Whoa, we have a diabetes diagnosis. What do we do next? And so, one of the groups mentioned metformin. I like where you're going. You know that that's the first line agent according to the ADA and the AACE, but we are not going to start that in hospital. And the reason that we're not going to start that in hospital, I'm going to ask if anyone in group 14 can tell me why, besides the fact that you probably just looked at my slides.
The dye.
So I suppose I will.
We're going to use insulin instead.
All right, very well. So we were going to use insulin instead. Metformin, we have issues with renal function. You guys have seen eGFR is what you're going to use to dose that medication. If you have renal issues and renal dysfunction, we can lead to lactic acidosis with metformin. And so one of the big things that typically happens in hospital, especially when you've had a heart attack, is imaging. And when you have imaging done, depending on what imaging you're having done, sometimes they put dye in your bloodstream so that they can see these images more appropriately. That dye wreaks havoc on your kidneys, and so you don't want to give metformin to someone, even though it is a first-line agent, but we don't want to give metformin to someone who's already going to have their kidney function working overtime because they're getting imaging fluid. So typically, and I've practiced across the country, I've never seen a patient in-house started on metformin for that simple reason. We want to avoid it because of the imaging that might be conducted and because of the issues with the kidney that can arise. So though I like the way you're thinking, and if any of the other groups had that as well, don't be discouraged. Metformin is our first-line therapy, but we're going to save that for discharge, okay? Not so much in-house. So we're going to avoid metformin at this time. But the other ones that I heard, whether we're going to start, let's say, a bolus insulin drip and convert it to basal when the person gets discharged, whether we're going to just start a basal insulin in-house, Remember, pharmacy is a gray area. So those are all options that can happen. But most of all, we need to treat this diabetes. We have this issue. It's something we need to discuss with the team. We'll need to check labs. So again, we have our labs that are done in the morning. It's likely that a CMP or a BMP is part of those. So we'll have the serum creatinines, the EGFRs, to make sure that our therapies, regardless of what we choose, whether it's an oral or an injectable, is going to be appropriate. Most people would tell you, let's start a basal bolus insulin protocol. And so every hospital that you go to has a little bit of a different protocol based off of what the patient's A1C is, what their fasting blood glucose is. And so that can be an option as well, and typically one that you'll see used by teams. But most of all here, what we're doing is we're collaborating with the patient and their healthcare team to initiate whether it be a basal bolus regimen, maybe just an oral therapy. And so this is what I mean by that middle part, that patient-centered care. If you have a patient who's afraid of needles, they may not agree, or they may reject or tell the nurse, I'm not taking that insulin for whatever reason. And so maybe the basal bolus or the drip isn't the option that we're going to go with, and we need to do an oral therapy in-house. That oral therapy can't be metformin at this point, but there are other orals that are available to treat diabetes that we can start in-house. And so making sure you keep the patient involved in this conversation as well as the healthcare team is going to be important. But I'm liking that you guys identified no matter what, at this point in terms of transitions, we need to make sure that this patient is being treated for their diabetes, okay? I also heard from the group that we're thinking we need to go from lovastatin to atorvastatin. It's a very good clinical catch. I told you guys to optimize those medications, and that's a perfect recommendation to make to your team. One that I'm sure as you guys go out on your APPEs next year, you likely will have to make in the future, okay? And so it's very often that we can make that catch for our physicians and make that transition to that high-intensity statin because this patient has had a heart attack, okay? She has clinical ASCVD, she's had her MI, and so putting her on that high-intensity statin going to be helpful here, okay? In terms of education that could be given, possibly her family or her caregiver is here with her at the hospital by now. I heard providing education in terms of diet and exercise when it comes to diabetes. My recommendation to you is to hold off on that until discharge. And reason being, this person just had a heart attack. I'm not saying that it's not important. That conversation needs to happen. But when we're thinking through the different transitions that we still have to go through for this patient, it could be that that conversation can wait so that you can be the most impactful. You tell them this day 2 on the cardiac floor, they're still worried about their heart attack. And so I like where your minds are in terms of making sure this patient gets the education about this disease state, but just my little tidbit here for you and my pearl, you may want to hold off on diabetes education until discharge so that they really absorb what you need them to absorb so they can go home and take the best care of themselves that they can. So at this point, really focusing on that life after a heart attack discussion is really what you want to do with the patient. And overall, and at all times, you're making a lot of interventions here. You gave the information for change to a high-intensity statin. You likely helped recommend and initiate something for care for diabetes. Make sure that you're documenting your interventions. Every hospital is a little bit different. Some hospitals have specific intervention trackers for the pharmacy department so that you can see the impact that you're having in terms of cost-saving dollars. But no matter what, you want to document what you're doing so that you have it indicated that you've had these conversations, whether it be with the team or the patient, okay? Other things that might be happening at this point, and one thing that none of the groups had said is it's possible that this patient needs a pain medication. There was no pain meds on her inpatient profile, and so maybe she's in pain. Maybe an opioid needs to be started. So if we do something like that, group 4, if we start an opioid or we start something like a pain medication, what other drug am I thinking should also be initiated if we give a patient an opioid?
What? Oh, didn't you look at the meetings with me? Okay, then I started over the top. No.
Does anyone else want to possibly share with me what other drugs should be started if we give our patient
We
an
got
opioid?
we just coming here.
Oh,
Do you remember that? From the Amanda show?
Could you hear that?
Say that again?
Our group said, like, something like a light stool or something.
Very good, nice job. So the stool softener is definitely something that needs to be started. Usually hospitals have these in, again, protocols for management of pain, so it doesn't get missed, but every once in a while you might see a pain medication, an opioid on the patient's profile with no stool softener. So making sure, keeping an eye on that as a pharmacist to make sure that the patient has that, always important. So that's one thing that I didn't hear from you guys. The other thing that isn't particularly applicable to her right now, because she isn't on any pain meds, typically they would be given IV at that point, but if she was on IV pain medications, this would be a really great point to think to yourself, can I do any IV to PO conversions, okay? So when a patient is on the floor, if they're on a lot of other PO medications, and say her pain is rather well controlled where she doesn't need to be on IV, IV to PO conversions is a great place where pharmacists can have a great impact. So thinking through those as well in terms of being on the floor. Is there anything else that any of the groups wants to add in terms of this point of transitions of care?
We were going to go ahead and counsel her on the medications we were going to give her now, since she's not used to taking this many medications and may have questions about it, as well as discussing like potential side effects or allergies she may have to them.
Okay, so counseling on the medications that she's currently taking in-house. So again, I don't disagree with that if it's focusing on the heart attack, but if we're thinking of all of the medications that she's possibly going to need to be discharged on, you want to think about the volume of that information that you're going to be providing to the patient. And I mean, just think about it for you guys. This class is 2 hours long, and I'm sure by like hour 1.5, you're going to be like, my gosh, I can't take this anymore. And so it's a lot of information. And even for a patient who doesn't have the same medical knowledge that we do, even a short amount of conversations when it comes to anything that's high level, like a heart attack or a new diagnosis of diabetes, is going to be really overwhelming. And so though I do think it's advantageous and it does have to happen that she's educated on her medications, you want to make sure that you're giving your patient enough and what they can actually write off and swallow instead of overwhelming them with all of the information at one time. So my recommendation to your group would be to possibly spread that education out over the time that she's here, but making sure that in bits and pieces she does get everything that she needs. What questions do you guys have for me? Awesome. So we are at the point, this is hospital day 3. This is pretty typical for a patient who comes in, has a clear STEMI, goes to the cath lab, and is stable. They can be discharged in about 3 days. So we're at day 3. She's been in the hospital for 3 days, and it's time to be discharged home. Our current inpatient medications are as indicated. We have accepted our atorvastatin recommendation, and we are now on a high-intensity statin, okay? And it seems as though the team has gone with a basal insulin of Lantus at 10 units daily, all right? That was the decision that was made. So I want you guys to take the next 8 to 10 minutes. Remember, this is discharge home, so this is your chance to really make an impact. Based on some of the things that you guys have already been saying to me, think through for the next 8 to 10 minutes, what kind of conversations do you want to have? And I want you guys to be specific with me in terms of, don't just tell me, I want to give her education about diabetes, but I really want to hear from you what it is you're going to say to this patient and how you're going to make it clear to them, and in layman's terms for them, what's going to have to happen when they get home. But don't just focus on the patient, because there's conversations to be had with your pharmacy care team, as well as your healthcare team, your physicians, your nurses as well. So remember, we're thinking transitions of care totally, that you can have an impact as a pharmacist. So on the patient, your healthcare team, even the caregivers. So go ahead and take the next couple of minutes. This one's going to be a little bit more hefty. This is your meat and potatoes, your discharge home. So take some time and really discuss it with your groups.
wouldn't.
I mean, we could.
We could, but I don't think we would since they're once he's 9. Can we use the metformin now that we're on the...
Metformin and BID. Like 80% of basal bolus plus oral meds. What? Remember that thing?
That's if you were on oral meds, right? And then start them on the oral meds again. And that was for the hyperglycemic crisis, wasn't it?
Oh, I don't know.
After a private med.
Less than 5, and then 7 to 9, and then greater than 9.
There's some words I just hate
What?
consistently. It's a hard one.
Oh, the spell. I wonder, depending on her injuries, maybe we can change an alcohol to something like something cheaper.
They stopped that. It's not the PPI, so we need to start H2R.
Oh, we need to switch it to that succinate, right?
Mm.
Why do you not use the card again?
There's just better data on the extended release.
I can't remember. I know this is so carbon. I mean, you see,
Oh no.
Okay. Go to accessibility, or general accessibility display.
It works on my phone.
Yeah.
Smart.
I'm sure Bob can help you.
Classic changes all of them to purple. Like it straight up inverts with two opposite colors right there. Classic or smart or all the white to the black. Oh wait. Oh, I don't like it. Yeah, I don't like smart.
I love this picture.
No, this one lifestyle change.
You want to keep looking at this?
yeah.
I didn't sleep well last night. I mean, it depends on the variation.
I was like, it's cold outside. When who? Or someone?
Oh, for real?
Someone.
It's too cold for all that. It's saying it's nice outside.
It is nice. It's really nice.
So smart invert like doesn't change your features. Wait.
We could be out for like 3 each. It's right before spring break.
Whoa. Going overboard with
Big thing. I told my
two of them.
like it's late, so I need to.
Like this?
Not really. But this is not. Like when I hold it, like I can't hold it like this. I need cushioning up here and oh my god. It's okay. Hilarious.
Josh Chow was like, his is around my time.
Weird, looks like a shoe.
I know, I do that all the time.
That's not shoes, but.
Here's Francisco.
Oh, he talked about 3/4 of the way done with my.
Is it your thing, dude? Did you just do your presentation?
Excuse me?
Excuse me?
No, we have different preceptors. I have Dr. Newsom. She's very relaxed about it. She gave me my topic.
But then since you already talked about the gave about it, or just
Oh, I get assigned a one?
Abicab
Did
is
you
like
not
a
see
part
the
of
professor?
experience and
No, no, the
BL
professor name is
sections.
who is,
I'm taking all the data from like the
Grading.
fracture and I just
No.
Oh, really?
I thought it was,
I think that's
that's
who.
your advisor. No, I'm pretty sure.
Oh yeah,
That's your advisor.
she texted me up.
I literally was in the car, but I was like, yeah, I can do this.
She's like, no, you're not. I can give you one. I asked Dr. Newsom, she said it'd be an okay topic. Toxic wounds is no longer, there's a lot of data suggesting it's not surprising, but no longer
Yeah, so like
suggesting
that
so you
topic
plugs are
is
other petrosite ones, but they can send me
Hey,
some
what's
better.
up?
Could review that. That's what I wanted to do before she told me no.
Why do you know?
Because she wanted me to do something media.
She wanted you to do something what? Meteor? Yeah.
That's funny.
And then there's an MS vaccination.